current and future transportation options to support independence. So we're going to begin with Dr. Kassab.
Okay, thank you, Ross, for the introduction. Good afternoon, everybody. All right, so let's start. I'm going to be giving 15 minutes today about a topic of driving in epilepsy. I'm going to first summarize quickly some of the state of Michigan laws related to driving with epilepsy. I'm not an expert on this idea. I'm just summarizing it for the sake of discussion. I'm going to be focusing more on the medical aspects of the topic, basically answering questions similar to why do seizure mean no driving? Is there a different type of seizures, and do they all impact driving? Can someone still drive if they continue to have seizures? What factors determine how long should the restriction last? And can the driving restriction or the no driving restriction change over time for patients with epilepsy, and how so? Before we start, just to remind everybody that the topic is very difficult and emotional. With several polls and publication in the medical literature, driving restriction is the #1 concern for any patient with seizure and epilepsy. This is why when I meet someone in the clinic and I'm ready to discuss this with them, it's difficult. I know it's emotional, there is fear, there is concern, and it may disrupt the physician-patient relationship because if somebody may get upset, you know, it's a lot of loss for independence when somebody cannot drive. So it's a difficult topic. And the second point I want to make that all the legal statements I put in this presentation are just a summary. So no legal advice you should take from this. It's only for the sake of discussion. And if you need the full version of the statement, you can refer to the Department of State website. Saying that, I'm going to go to two clinically relevant points to make clear before, because it's going to help us with the discussion later on. The first one is, what's the difference between seizure and epilepsy? Aren't they the same? People using them interchangeably all the time? The answer is no, and it's important to know for this topic. Seizure can happen to anyone if you stress them long enough, like if you deprive them from sleep, for example, if they have an acute illness, if they're withdrawing from alcohol. That doesn't mean they have epilepsy. That doesn't mean they have a condition that will let them have seizures all the time. Now, if the patient or the person have a condition that will manifest itself by making them have seizures unpredictably all the time, then we call them they have epilepsy. So it's going to become important when we discuss should we or should we not restrict somebody if we know, for example, it's a one-time seizure most likely because of a certain something happened. It's different than what we know if somebody, for example, have a stroke or lesion in the brain that's going to interrupt electricity all the time and they're going to have seizures all the time. Now, the second point that I want to clarify as well is is there a different types of seizures, and do they all impact the driving? And to answer that, you need to know how do seizures generate. Seizures generate when a group of cells in the brain decide to fire electricity on their own without the patient's will. Now, this is important because it depends where this area in the brain that decide to emit the charge, you will have symptoms according to that area. For example, if the area is in the motor area in the brain, then you will have an arm shaking, face twitching, leg shaking. If it's in the sensory area, you may feel just some numbness without knowing why, or as if somebody's touching you, but there is no one touching you. If it's in the awareness area, on the memory area, you may lose consciousness. It's only when this spread all over the brain, and they do not spread all the time, but it's only when they spread is when we have the classic everybody know about generalized tonic-clonic seizure, where somebody loses consciousness, go on the ground, stiffen, and start shaking. So knowing the difference between seizure and epilepsy is important in our discussion. Knowing the types of seizure and which one gonna impair driving is gonna be also important in our discussions later. Now let's go to some summaries of the Michigan driver license laws. A person with epilepsy in Michigan must submit certification that A, the condition is under control, and B, their last seizure was 6 months ago or older or before. Now, the 6-month period may be reduced. This is in the laws of the Department of State, may be reduced or eliminated based on the review of the specific recommendation from a qualified physician. And we're going to talk about this a little bit later, what factors may lead us to reduce that 6-month period. Now, for commercial driving, the restriction for when the last seizure is longer, the patient should be seizure-free for 1 year. Again, the second point is similar, that this 1 year may be shortened based on the specific recommendation of a qualified physician. One thing to point is the drivers of school bus should, under no time period, if they are diagnosed in epilepsy at any point, should be driving school bus. And this is by the laws of the Department of Education and guidelines. Now, reporting. This is also a thorny topic. There is no obligation from the state that the physician should report the seizure to the Department of Motor Vehicle. So if I have a patient in a clinic, I've diagnosed them with epilepsy, I told them they shouldn't drive, I am not required to report this to the State Department. And this is a blessing in a way, because first of all, it's not gonna cause this tension between me and the patient. It will allow the patient to always tell me when they have seizures so I can treat them better. I don't want to put myself in a situation where, okay, I'm not getting the right information on my patient because they didn't tell me if they have a seizure in the last 6 months because they want to keep their license. I want to know if they have seizures so I can change the medication or modify it so I can get them seizure free. So this is a blessing in a way. However, that doesn't mean that the people with epilepsy should go ahead and feel that there is no pressure on them to drive. And these are the penalties that I picked from the website. I mean, it's kind of scary. I mean, you can be, if you're driving without, against medical advice, that, by the way, we document in the clinic, in the notes, that we advise the patient with epilepsy not to drive. We do not share it with the Department of Motor Vehicle, but it's there. God forbid, if there's an accident, they have access to these. And if somebody was found to be driving against medical advice, without a valid license, without acknowledging the physician or the Department of Motor Vehicle of any change regarding this condition, they may be under civil infraction, fines, cancellation of their license, or even criminally liable if, again, God forbid, something bad happened, like hitting another somebody and causing loss of life. Now, this is the slide that I'm gonna spend most of the time on, and I think I'm 2 slides away from the end of this presentation. What are the factors in the medical practice that determines which epilepsy or which seizure should be restricted not to driving, and which ones should be restricted and for how long, and are some of them less than 6 months or indefinite? So usually, number one is, of course, a no-brainer, seizure control. If somebody reached control on medications, they have no seizure for 6 months, yeah, they can start driving, no problems. They need to take their medications. It takes us to point number 2, they should be adherent to their medication. They should ask for refills on time. If we check blood test for levels of medication, they should be always in the therapeutic range. You know, and if there is no adherence, that will raise a lot of red flags, because sometimes when you run out of medicine, it's more dangerous and more likely to have a seizure rather than not taking a medicine. So there should be a consistency in taking medicine, never skip a dose or try not to skip a dose, and definitely not more than 1 or 2 doses. You should ask for refills on time. Now, driving records also plays a role in the decision making. When somebody comes to clinic, you know, they're saying that they're seizure free, but they're having several driving accidents in the last 6 months. That also raises a red flag. Now, there are circumstances where we say, okay, even though you had a seizure in the last 6 months, you know, maybe a month, 2 ago or whatever, but we are gonna let this go and we're gonna present the case to the Department of Motor Vehicle that this is okay if one of these cases happen. And I only put the most common ones. For example, somebody is very well controlled on seizure medications and all of a sudden they got sick, they had a fever, maybe they vomited, they couldn't keep their medicine in, and they had a seizure. That's a seizure in the setting of an acute illness. That's a provoked seizure. They don't have to wait 6 months. Once the acute illness passes and they are back to normal, they're taking their medicine, they're allowed to drive. A second scenario, nocturnal seizures only. Some of the patients with epilepsy only have seizures at night. They never, ever have seizure during the day. They can drive during the day. Of course, that all comes with a medical history and observation over a long period of time. Another scenario, situational or reflex seizures. Depends on the area of the brain. Some stimulation from the outside may trigger people's seizures, and only when these stimulation happen, they have seizures. For example, I have patients who cannot stand looking at the police or fire truck sirens. The red light turning, flashing causes seizure every time. So this is situational seizure. Other patient, I have one who have seizure every time they listen to a certain song. So if they avoid these, they never have seizure. So these people can drive if they can avoid these situational circumstances. We talked about during acute illness or toxicity. Again, let's see, types of seizure. We talked about if the seizure coming from a certain area of the brain and not spreading, it's always like that. Some patient can drive even if they have a seizure. For example, people with seizure manifesting itself with facial twitching only for a minute or so and they disappear. A patient that have numbness in the thumb or in the arm, right arm, and then it resolves. It never generalizes to make them lose consciousness. It never spread to the leg, for example, to cause a problem with stepping on the gas or the brake. These people can drive. Seizures with consistent prolonged aura. Some patients are lucky to have a warning before their seizure. Like they can tell when the seizure is coming. And if there is enough time between that warning and the seizure, then theoretically they can drive. Some people, they have the warning, but it's only a couple of seconds. That's not enough. Some people never have a warning, but some do have a warning a good minute or so before a seizure hit. And theoretically, they can, park at the side of the road or stop the car somewhere, and just in case they are having a seizure. And lastly, provoked seizures. That's again, somebody have epilepsy and they are on their medications, but they had this trip camping somewhere. They couldn't sleep at night. Sleep deprivation is a very well-known trigger for seizures. We also advise not to drink, but sometimes it happens. So any trigger that caused the control of that seizure to break in at least one time doesn't mean you have to wait 6 months. We have just to document it that most likely it was provoked. Patient is back on their seizure medications. They're not going to repeat the circumstance that led to this, and we can potentially allow them to drive. Last slide of the presentation. Can the restriction or the no restriction change over time? The answer is yes. Seizure and epilepsy. Epilepsy is a very dynamic disease. It changes over the lifetime. People who are controlled now may not be controlled years from now, and people who are not controlled now, all of a sudden, they may be controlled later with the inventions of new medications all the time and devices. So the point that I want to make, it's not an ultimate, like, final decision at any point in time. This is why it's important to always follow up with your physician, and any change in the seizure semiology, like, or habits, like it's changing, doc. I mean, I'm seeing stuff that wasn't there, or I'm feeling stuff wasn't there before. Then I know something is changing. Then we have to talk about it, change medicine, or observe it more carefully and give advice. So I hope I gave a good summary. I will stay and look forward for your questions, and thank you all for attending.
Great, thank you so much, Dr. Kassab. I'm sure we will have a lot of discussion about that when we're done with all 3 presentations. So now we're going to transition to Sarah Green. So Sarah, if you can unmute and share your video, and then share your screen as well.
I put this presentation together before March, so I wanted to give a few updates. Since the stay-at-home, stay-safe order, public transit is encouraging individuals to take transit only for essential trips, and our ridership currently is down between 60 and 85% on both our fixed route buses, and those are the regular buses that you see pictured here, and our GO buses. Both of those services are being cleaned, sanitized each night, and after each of their runs, we are doing touch point cleaning. Masks are required for individuals and our bus operators while they're in transit, and we are limiting the amount of passengers on the bus to 15 passengers instead of the typical 35. On our GO buses, which is ADA paratransit service, those are limited to 2 people as well as the driver on there. Okay, Russ, would you mind forwarding this next? Thank you. So in travel training is what I do at the Rapid, and the Rapid is our local public transit agency. And we offer this service either one-on-one. I think you might have skipped one slide. You want to go back one? Okay, that's fine. We can work with this. Go back the other way. I apologize. Okay, so we have different types of travel training. We go one-on-one with individuals, or we take groups of perhaps somebody from a transition classroom or a person who maybe doesn't speak English, limited English proficiency. We take groups or individuals who need extra assistance in learning how to use the bus. Okay, you can go to the next slide. So when we're out working with individuals, we give them information on how to use the apps with real-time bus information, safety awareness, path of travel suggestions, landmark identification. What we do is we fade our assistants. I've been travel training here at the Rapid for 21 years and have worked with many individuals, and we go to and from the location that they'd like to go, primarily work and school, but we'll also do training for individuals who want to go out to the mall or learn some new routes along the way. We give them fare information. We provide the fare while we're training. wave card information, which is, I'll talk about in one of the next slides. We can go to the next slide. The wave card is something new that we have here in the Rapid, and it's a fair media option where you can tap and board. You can download more fair media on your internet, or you can load it at our central station or at numerous outlets in the community. You can load money if you're a person who perhaps is unbanked. So we have to give these opportunities to everyone. And it always finds you the best fare. You don't have to ask for a transfer. We were going to stop accepting paper tickets in June, but with the COVID, this is extended. So right now, probably until the fall. ADA passengers, those are individuals who are ADA eligible or eligible for the GO bus. It saves the transit agency considerable money if individuals are having a good day and they feel like they can take the regular fixed route bus. We offer free fare on the fixed route bus for individuals who are ADA eligible, someone who's certified as ADA eligible. So they can just tap and board any bus anytime and not pay a fare. It saves them the $3.50 each way on the GO bus. And it saves the transit agency a considerable amount because those GO bus rides are expensive to provide. So if someone's having a good day and feels like they can take the regular fixed route bus, we'd like to encourage them to do that. It's the least restrictive mode of travel. Individuals who have a disability, including epilepsy, can get reduced fare wave cards, and they pay half the regular fixed route fare. Okay, you can slide to the next one, Russ. Thank you. And this is just a picture of some of the individuals that we've worked with. We work with Leader Dogs for the Blind, orienting these dogs and their handlers to the fixed route bus. This is a picture of our Silver Line. The Rapid has the first bus rapid transit system in the state of Michigan. We got federal dollars to provide, it's like a train on bus wheels. It's limited stops, and it's called the Silver Line. Our second one is opening in August, and that's called the Laker Line. These buses are, they have fare enforcement officers on them. They speed up boarding, they speed up travel. They only stop at certain stations along the way. So we also work with many transition age groups. We work with individuals who like taking groups of social workers, limited English proficiency anyway. Those are some of the outreach things that we do. You can slide to the next. And individuals who are visually impaired will work with an orientation mobility specialist, and we'll show them around the bus. We'll give them the opportunity to see what's inside, where the fare reader is, and what the insides of the buses look like. We'll take an out-of-service bus out to their home or to their school and work with them in cooperation with an orientation mobility specialist. Next slide. ADA applications, individuals who are ADA eligible. This is a federally mandated, federal guidelines indicate that an individual who applies for paratransit, the application has to be completed within 21 days. The applicant must be prevented cognitively or functionally from using the fixed route bus some or all of the time. This paratransit review is done either, what we do is we take the applications here at the Rapid, then we send them to our paratransit evaluator, which is our local CIL. An occupational therapist reviews the application or calls the individual for an interview, or sometimes we'll do an in-person assessment, which is with the participation of the travel trainer and with the occupational therapist, and we do that in combination. Federally, we had been recognized as having best practice for this. If we have a person with low vision, we often employ the services of an orientation mobility specialist. So there are 3 people with different venues of expertise that meet with the person. So determining ADA eligibility is very important, and it's a it's not one particular disability, it's whether or not their functional or cognitive abilities prevent them from using the bus. It's not saying that the individual may not have a disability or that a certain disability always qualifies. We have to go on a case-by-case basis. So individuals can be conditionally eligible or unconditionally eligible, or sometimes individuals are denied, but there's a whole process that's federally mandated. GO Bus is a shared ride public transportation service with advanced reservations, and the fare is $3.50 each way. Fixed route, which is where our regular buses go, and GO buses travel in the same area, just 3/4 of a mile beyond. We serve Walker, Granville, Wyoming, East Grand Rapids, Kentwood, and parts of Cascade. The GO bus travels where the regular fixed route bus goes. As I said, 3/4 of a mile. It mirrors that service, and it can take about the same amount of time as that service. It's not like a Lyft or an Uber. It's shared ride, advanced reservation currently in Grand Rapids. Next slide. So again, this is our system map. We have a nearest stop indicator on our website. There's a lot of good information. You can plan your trip. You can put in your location, where you want to go, and it'll pull up how to get there and the best way to do that. On Google Maps, there's also, you may have noticed little icons. There's a transit option. There's a bicycling option. There's a walking option or a driving option. So in Google Transit, you can click on the transit option. We'll go to the next slide. And then Rapid Connect, we have real-time GPS located buses, so you know when your buses are coming. You can also get rider alerts and information as it comes along. Currently, we had cut service with the pandemic and the stay-at-home order. We had cut service to 7 to 7 on weekdays. We just extended it from 6 a.m. till 10:30. Weekdays, and then Sundays the service is a little less. So GO Bus does whatever the fixed route does, and we did that in order to keep people safe and to limit the amount of people that were traveling. But slowly, I think we'll start to build up. And we'll head to the next slide. So as a travel trainer at the Rapid, I've developed partnerships and advocacy working with other agencies. And one of the things that we've done, again, DAC, which is the Disability Advocates of Kent County. This is a picture of some individuals who are advocating for sidewalks along 28th Street in Grand Rapids. That was a street that had like paths worn where people were walking and using. We have a route that goes all the way across 28th Street, and there were no sidewalks, and it was very dangerous. So we advocated, that's our board chair doing a ribbon cutting with the mayor of Grand Rapids in getting sidewalks from one end of each municipality along 28th Street. We've got sidewalks. In 2012, we invested near $950,000 in putting cement pads at all of our bus stops to make things accessible. And the city of Grand Rapids and the Rapid also just put in $100,000 to make amenities, bus stop shelters in our downtown area. And we're also doing, the city of Grand Rapids has also got a pilot program that they did last December to clear the streets of snow. So you can go to the next slide. This is something that is a City of Tomorrow grant, and this is May Mobility. This is one of the I'm trying to think of the word for it, I'm sorry. Autonomous vehicles, there we go. This is not the Rapids program. This is the City of Grand Rapids went and got a grant, and I believe it was the City of Tomorrow grant from the state of Michigan and Ford. And Ani is going to talk a little bit more about this. These are accessible vehicles that have an attendant on board. And it was a pilot project just to see how this would work in an urban environment, kind of preparing the community to see these autonomous vehicles, and they created a lot of buzz. Unfortunately, with the pandemic, they stopped running in March, and they're hoping that they can get them back up and running in October through the end of the year. But they did stop running, but while they were running, they created quite a buzz. And then the next slide. This is the routes that they took, and it had 4 vehicles. And then this is a dash bus. This is a circulator that goes downtown. It's designed for individuals who maybe are working downtown and just want to hop on a shuttle to go from one point of downtown to the other, or people who are driving and parking to get them into the center city. Next slide. So this is a quote from our CEO regarding public transportation and the transformation in the community. After the pandemic, we'll see how things go. I anticipate that you know, the support of the rapid that we've received from the community will continue, but things are going to look different, and we'll be open to new mobility options in the future. Russ, is there time for the video?
Yeah, I think we're actually going to skip the video, but if, I will share the next slide. So if anyone wants to try, I'm not sure if you can.
This was just an individual that I worked with one-on-one travel training. So I'll thank you all very much.
Just to watch this video, just contact me after today, and we can get you the link for this. So just in the interest of time, I think we're going to move on. But thanks so much, Sarah, for a great presentation. And we are going to transition now to Ani Grigorian.
So my name is Ani Grigorian, and I'm going to talk a little about a lot of things about what transportation might look like in the future. So who am I? So I am a geriatric social worker turned systems designer operating my own accessibility consulting firm, focusing on how we move throughout and interact with our environments. And I'm really focused on sort of the equity, aging, and access components of building more inclusive transportation infrastructure. And so I get to work with big companies like Ford and Red Bull, but also grassroots organizations like Detroit Disability Power and Allied Media Conference. But in general, I grew up in an automotive expat family where I lived all over the world, and I'm bringing a lot of this global awareness to the work that I'm doing. And so I thought it was really important to recognize the violence against our Black communities that is continuing still, and thinking about the role that transportation plays as a tool in oppressing people. And so where you live depends on how and when you're able to access basic needs such as employment, food, education, childcare. And so it's really important to understand that when we don't have Black and other minority communities in leadership roles as policymakers, as entrepreneurs working in this space, we're perpetuating a lot of the political and social structures that are keeping, you know, people oppressed. And we know that poverty is both a cause and a consequence of disability. And since Black communities are twice as likely as white communities to live in poverty, the relationship and intersection between disability and the Black community is something that we really need to have in mind when we think about the future of what equitable transportation systems look like. And so just in Detroit, it's estimated that 120,000 people are disabled, and 100,000 people are Black from this number. And the reality is that we don't have really good data, and we're not really tracking how things are changing over time as the city continues to gentrify. And, you know, COVID-19 is a really important, you know, piece of this puzzle. We don't have good data. We're not tracking disability in terms of who's contracting COVID, how are people contracting it, how are they spreading. And the people that do have some of this information are systems like our paratransit system and Medicare and Medicaid providers, but there's still, thinking about the future, we need to have more of an effort to build public-private partnerships and pilot solutions that navigate privacy and these equity goals. And so other things that we really need to think about is the work that we need to do on ourselves. How are we going to appoint more Black leaders? And just in general, checking in on our Black colleagues, family, and friends. And so where are we at in terms of how the disabled community is included in this mobility ecosystem? So right now, I think people are still shifting away from the medical model that use diagnosis to identify rather than understanding the social model of disability, which accepts and understands that disability is a normal part of the human experience. We all have complex needs and accommodations. And something that someone I work with mentions is, if there weren't stairs, this person uses a wheelchair, if there weren't stairs, would I be considered disabled? And the answer is no. And so within the mobility industry, we need to recognize that disability is very diverse, and designers try to create archetypes for people and put them into categories. So you want to design for a person with one particular disability rather than trying to remove access barriers and design solutions to be a little bit more universal. And we see a lot of this in headlines where accessibility and inclusive design are used interchangeably, and that's not really the case. Accessibility, to me, I understand it as features that enable people to access something based on what accommodations that they need, versus inclusive design is a process and how we are engaging and giving power and tools to the people that are going to be using the solution to design that solution the best way that it works for them. So something that's ADA compliant doesn't necessarily mean that it's inclusive, but when you're seeing things in the news, you can see how things are used interchangeably. And this brings up a really great thing for us in the disability community to think about, is that people who are designing these solutions are really eager to engage the disability community. And what kind of opportunities does this create for us? What do partnerships look like? What should they look like? And to me, that means paying people with disabilities, and again, giving them the tools and the power to design these solutions in the way that best meets their needs. So general things that I want to touch on is COVID-19. So with COVID-19, we saw able-bodied people get accommodations that disabled people have been asking for decades. So things like remote work, remote education, being able to, experience concerts and live streams from their homes. And now that disabled people, sick people, and especially older adults are getting a global platform, how are we going to retain this and fight for accessibility when we start to sort of see what I hope is a hybrid model of accessibility in our physical world as well as from our homes and in the digital world? So another important thing is that mobility is cultural. There are some countries out there that value collective investment in public infrastructure, and they value older adults and disabled people, and so they're automatically designing with these things in mind. Barcelona is a really great city. A lot of different cities in Korea have amazing infrastructure, as well as places like Singapore, where 80% of older adults live in public housing supportive services. And so another thing that's changing is a lot of startups and even cities and companies are realizing that we can't just rely on the people who are riding or using the service to be fully responsible for payment, because transportation is so expensive to operate. And so there's a lot of work being done to research, okay, if we invest this much in transportation infrastructure now, how much does it save in terms of healthcare? If people are able to, if we cover transportation for people's healthcare now, what does that save all of the people involved? And something that is starting to come up in conversations is, how are we able to have systems level stakeholder fair costs? So can the state cover some? Can healthcare and insurance companies cover some? Can the riders cover a little bit too? So how are we going to subsidize and share these costs that are really expensive? And so one of the sort of trendy human-centered design processes happening now, something that Sarah had mentioned, are these design challenges. And so a lot of times they're public-private partnerships that encourage people to, whether you're participating in the challenge as like a community member or as someone who's proposing a solution, but you can crowdsource information and knowledge and share that knowledge in order to solve a problem that they have addressed. or asked to be addressed. And so the state did this Michigan Mobility Challenge, and there's more information on their website. But right now, the federal government is doing an inclusive design challenge. And there was a webinar, I think, on Wednesday, but more information is starting to be released and it's coming out soon. So Sarah mentioned the City One Challenge, which is one of Ford Smart Mobility's initiatives working with cities to source and leverage some of these solutions. But to me, there's a lot of barriers with these design challenges. There is a serious equity problem with who can participate. The people who have the knowledge and the skills, but maybe not the resources to solve some of these problems, typically can't volunteer their time and their energy to participating in this. It doesn't solve systemic issues that are really needed in order to combat a lot of the exclusion happening within our transportation infrastructure. And also the sustainability is something that is important to understand. If a pilot program gets $80,000 to pilot, what happens when that money runs out? They still are going to have money after that in order to continue operating a service. And so those are some of my personal barriers with accepting this as a really great solution. But I know that it's, it works for some groups in some states. And so I want to talk about our streets and bike share. So in Detroit, our bike share system is called MOGO, and they were the first group in the US to launch an adaptive bike share service that they developed with a disability organization out of Ypsilanti. It's available only in the summer, and they have 13 different prototypes of bikes. So the picture on my opening slide was from a demo I did with the organization I work with, Detroit Disability Power. But something else really great that's happening in a lot of communities, including my own, is that we're investing in new complete streetscapes and understanding that good transit requires good walkability and prioritizing health of people over cars. And so a lot of the technology that is happening really all over the world, a lot of research universities too are involved in this, is they're integrating sensors into streets to collect data on how people are moving, safety of intersections, in order to identify air pollution. And so there are maps and ways that people can add on and create routes. So if you're someone who's triggered by really poor air quality, you can create a map for yourself that uses a route that avoids poor air quality. And so this streetscape that I shared is of my neighborhood in Detroit that I believe we're starting construction in the fall. I live on 12th Street in Claremont, where the 6/7 uprisings in Detroit happened. So here used to be all lined with Black-owned businesses, and you can see what it's like now. But slowly we're starting to develop better infrastructure that prioritizes our neighbors and our communities over just cars. And so I'm going to talk a little bit about the technology trends we're seeing. And so one thing that is really excelling overseas and not as much here in the US, although little by little we're starting to catch up, is something called mobility as a service. And so what mobility as a service is it's IT-enabled multimodal connected services where users can look up real-time data, they can reserve, track, create routes, and pay all through an app. And in the US, what this looks like is Uber, for instance, in Uber's app, since they partnered with Bird, the scooter company, you can plan a route where you're looking up how to use an Uber and a Bird to get to a destination, and you can reserve and pay for all of that using just one app. And so there are a lot of different software companies and a lot of technology that's available for people. And even for these autonomous vehicles, the technology is really there, but if offline operating infrastructure isn't there, then the technology really means nothing. And so what's happening offline is really needing to catch up, and it's a lot more complicated than just building software. And so I do want to bring up transportation network companies such as Lyft and Uber that have revolutionized transportation in a way They sort of worked by using underutilized assets, so vehicles that people are personally owning. But it's important to ask yourself whether they are a mobility company or a technology company, because when they're sued by ADA, they call themselves a technology company. But when they're going after equity and health-based grants and opportunities in order to serve the community, they are considered a mobility company. So I'll let you make your own conclusions. And so autonomous vehicles, this is something people are really excited for. I have here sort of the different levels of autonomous vehicles, but I want to talk about the health integration in vehicle experiences that, in terms of health, I think autonomous vehicle companies are including the disabled community quite well when it comes to health integration. So sensors in your steering wheel or in different pieces, maybe not steering wheel, but different pieces throughout the vehicle where they can tell if your heart rate is changing, if there's any change in your health status. Your wearable technology that you might be using, compatibility with additional wearable technologies is something that's fairly easy to integrate. But thinking about in-vehicle experience that we're used to and what can be is really limitless. So thinking about how people can now come to your home using telehealth. Telehealth is really going to be available anytime, anywhere if your vehicle is able to do that too. When you're on the way to pick up your groceries, you can have your vitals checked and that information can be sent to your doctor. You can go and pick up things from the pharmacy on your way home from getting groceries. So all these different needs of yours are going to be integrated with your vehicle. But in terms of concerns within the disability community, we need to be concerned about privacy, and we really need to be concerned about how these vehicles are going to be universally designed to accommodate a wide and diverse range of needs. And so I did include May Mobility here because they have been an organization that I've worked with just a little bit. But the reality is a lot of these technology mobility companies launch in cities where they're enabled by policy. And so when they are creating ADA solutions, is it because they had to get public money, or is it because they really want to serve this community? So those are questions that I always ask organizations that I'm working with when they come to me trying to understand how to make their products more inclusive. And so cities that I think are doing a pretty good job, depending on whether you're looking at their policies, their technology, their attitudes of adoption, how cities are encouraging autonomous enhancements. Singapore, the Netherlands, Sweden, and in Ann Arbor. I think those are cities you can follow up and see. And so something also cool with technology is it's making how we interact with transit easier. And so there's a company called Looking Bus that has won quite a bit of money from different of the City One challenges, and I believe they won in Austin. I think they got some money in Grand Rapids. I think they're launching in Lansing now. They're based out of Ann Arbor, but they want to make transit available for blind and visually impaired users. And so they're also addressing this by working with drivers. So drivers are prepared and trained on how to support their riders that have visual impairments. Another company is called Transit Screen, and they have a number of different products, but the one that I think is really cool, and you see a lot of these in cities like New York and DC, where they have literal screens that has all this different kind of information so that you can understand the information that you best need to make transit work for you. And so more wayfinding technologies that are important to highlight. AbleLink is one that won second place at Ford did a City One challenge through the city of Detroit for the train station as part of their community benefits ordinance. And they won, I think, second place, but they have money to test their innovation, which is supporting people with cognitive disabilities, building routes and traveling through areas using public transit systems. But it is available for individuals if you want to purchase it for $350. It's a lot, but that's why I think they really encourage working with local transit agencies. And a company that I've done a little bit of work with out of Barcelona, they started in 2012, And they were originally designed by a man who is blind, and originally for people with visual disabilities, but they have a similar concept where they are using an app and guiding people step by step with GPS and environmental clues through their routes. So from their homes all the way to their destination. And they work with local transit organizations so that there's somebody monitoring that person who's using that app and making sure that any support they need, they can just go ahead and call that person and help them. And so another big thing with this is that they're really trying to make sure that they free up paratransit use for people who need it, if this innovation can help people use regular routes. And I think that's an important inclusion piece to understand too. And so I'll just talk a little bit about rideshare and microtransit, but these are two other, I'm going to call them buzzwords, but I'd rather talk a little bit about these brands here. So Rally is a company that started using, started working with motor coach companies. So essentially, if you want to go to a political rally, if you want to go to a stadium, if you want to go to a concert, so big events where a lot of people are going, they crowdsource a route based off of who signs up and where they're going. And so if you're the first person to sign up, you pay for a spot at a low rate, and they guarantee your trip after 40% of that motor coach is accounted for. And so Wheelie is a ride sharing service that primarily works with college students who have vehicles, but supporting college students who don't have vehicles, who need to get to class, get to the grocery store, and do what they need to do. And so locally, Hope Network has a program called Wheels to Work, where between you and your employee, you cost share how much it costs to get to work each day, so trips to work. And healthcare is probably where transportation is including disabled people the most right now in the healthcare and wellness space. So Kaizen Health is out of Chicago, and they essentially are coordinating rides with a diverse fleet, so taxis, small vehicles that have car seats, buses, wheelchair vans, and they are working between all the different players, so healthcare companies, transportation providers, hospitals, and insurance payers. So sort of what I said at the beginning about how people are starting to share costs and share responsibility. So they're a company that's doing this, and one of their primary focuses is on care coordination from the ER and making sure that you're meeting your follow-up appointments. But I'd like to end on talking about why it's so hard to have reliable, affordable, accessible transportation. And the reality is that it costs a lot of money to operate accessible transportation. And as you get more specialized in your equipment and training that the drivers need and the call centers, and as you do become more universal, your operating costs increase. And for instance, in Michigan, we have really high insurance costs. And because for wheelchair vans, because it's considered a risky business, although it shouldn't be, insurance is going to go up. And so you have to price based on whoever's paying in order to survive. And so something about operating is that throughout the day, you have to have enough rides to cover your cost. And wherever your service area is depends on how many rides you're able to do at a particular time. And so you want to also charge based off of what hospitals are willing to pay for this, what nursing facilities are willing to pay for this if this is non-emergency medical transportation. But you also, in order to be inclusive and accessible, my first project out of grad school was building a business with Ford Motor Company operating wheelchair vans, serving nursing facilities, hospital systems, and getting a little bit of insurance payers in. And so in order for us to survive and be sensitive to people's needs, it was a constant balance of being able to afford to operate. And so the reality is that the more specialized service you're in, the more expensive it is because of a number of different factors. And so it's sort of this balancing game that I don't really think anybody's figured out yet. And so the future is really going to depend on if we're able to get subsidies from a lot of different people to cover the real needs of riders. And so I think that's all. Yep, that's all I have.
Okay, excellent. That was really exciting stuff and really important things to consider there and when we're planning for the future. So I'd like to invite Sarah and Dr. Kassab to join us, to unmute yourselves and share your video. Sarah, I know Dr. Kassab, you can't, but Sarah can share your video. Great. And we're gonna have probably about 15 minutes or so for Q&A. So we have a couple of questions queued up here. And again, I encourage you, as we're discussing, or if you think of anything else, please submit your questions through the Q&A feature. Okay, so let's get started. The first one, I'm gonna read verbatim. It says, I used to drive a car. Are there going to be any changes to the Michigan law regarding how many years one has to wait till they get their license back? Dr. Kassab, do you have any thoughts on that?
Not really. It sounded more like a question to the lawmakers rather than me. I'm not aware of any changes, but I don't know.
Right. So just to kind of piggyback off of that question, maybe if you can talk a little bit about what, if you're aware, what was the process whereby a safe period of time of seizure freedom was determined? Was there some sort of consensus panel or process that led to some states choosing 3 months and some choosing 6 and some choosing a year? Can you talk more about that from at least from a neurologist or epileptologist perspective? What's the rationale for that 6-month time frame?
Yeah, there were a few studies that were done, like what's the likelihood for somebody who's a certain amount of months seizure free to have a second seizure. And it looks like, of course, the more you stay seizure free, the more likelihood that you're going to be seizure free or controlled. So it looks like 6 months is close to the 85% chance of being seizure free. Of course, 1 year is about 95%. So you'll have to pick a reasonable, marker. So I think the Michigan legislators just looked at the data and they felt comfortable, like the majority of other states, with 6-month period.
Okay, great. And another question, does having nocturnal seizures disqualify you from getting or renewing your license? I only have them in bed, he says.
No, actually, this is a good thing. If all what you have is nocturnal seizure, then you can drive during the day. And I think I mentioned this in one of the slides.
Great. So I remember from a previous conference that we had, and I wish I knew what the source of this data or this statistic was, but I had one of the presenters, who's an epileptologist, said that the risk of someone who is seizure free for 6 months of having a seizure while driving of having an accident is similar to that of an 18 to 25-year-old male. And I thought that was an interesting way of thinking about it, just because there's no one is completely free of risk of accidents. And so really what we're trying through this law is to make sure that people who are driving are in a reasonable risk category. Have you heard of that statistic before, or because yes, I haven't qualified?
No, I did. So the risk of having an accident for people with epilepsy is probably 1.5. I mean, the extra risk. If the general population is 1, it's 1.5. It's not even. And on top of that, what you said is true, but on top of that, the young people have higher mortality rate when they have accidents, where the people with epilepsy have a much less mortality rate when they're having an accident. All this go into a factor in determining how long you need to restrict the license for.
Okay, right. A question here about someone or sharing a story about being a cautious driver and a safe one, but had a non-seizure fender bender and then was searched by police and had a bad experience. Is anyone aware of or heard other experiences of people with epilepsy having being discriminated against and because of, and assuming that an accident is related to their epilepsy when it could be completely unrelated?
Well, it certainly, I can certainly see how that is possible. The ones that I deal with mostly are like a post-ictal phenomena when, you know, the officers or the, you know, they're trying to figure out what's going on and somebody's not making sense, and then they got really in trouble for that, for the officers not to understand what the post-ictal phenomena is. But I can see how immediately a red flag can be raised if along the way of investigating an accident, somebody knows that you have a past medical history of seizures.
Okay, so someone was saying that their daughter is going to be a junior high school student and as a parent, she's very interested in learning how she can help advocate for transportation options for her future. Maybe Ani or Sarah, are you aware of any organizations or advocacy groups that people can get involved with to advocate for improved transportation?
I know sort of on a local level, each city will have their own. So I know in Detroit, but I'm not sure outside of my own city, to be honest. So if people are in Detroit, there's a lot of you know, justice-related organizations that are doing that work.
Locally here in Grand Rapids, we have Disability Advocates of Kent County, or CIL. They have a group called Concerned Citizens for Improved Transit. We as the transit agency can't necessarily go out to a township and say, we need you to have transit. The people who live in the township have to go to their local leaders, because so often there's a patchwork where the city will be served and then the outlying districts won't be served. So here in this Grand Rapids area, we have yet to get countywide service. Flint has countywide service, but Detroit, Grand Rapids don't have countywide service. So it's all, you know, before you move, before you send her to school, check and see what the transit options are. And I know that's hard for people because they might live somewhere and not realize they're going to have a child with epilepsy, but it's so important to look at what's available.
Right, right. And we emphasize that a lot when you are at a point where you are, you know, going off to college or starting your life on your own, that where you end up locating, you should absolutely consider what their current transit options are like, because a lot of people end up settling somewhere without having thought of that, and then they're kind of stuck in a position where there's just not a lot of good options. So, and
so often with baby boomers, that men outlive their ability to drive by 10 years and women outlive their ability to drive by 6 years. You got to think about it. When I was relocating, I thought of those things. Am I near a transit stop? Is this where I need to be? And keeping active as far as bicycling options and walking options and those kinds of things. It may be cheaper to live out in the suburbs, but if I can live without a car, that's a better thing.
And developers are starting to consider transit-oriented development. I think there just needs to be more done in terms of like advocating for what needs to be prioritized, and so that you're not having different pieces that make, you know, a more universal space. You're having all the things that people need, health and wellness, but not just for young people. We're seeing the development is very geared towards people like me, but not towards older people. But in a city like Detroit, we're very polarized. We have a lot of young people and a lot of older people. And so how do you advocate for communities, for living spaces that work for the most amount of people?
Right, right. And just to reiterate what you said, Sarah, about this Center for Independent Living or Disability Network, this is the newer term for them. So if there's regional areas, and each regional area has their own disability network or Center for Independent Living, and many of them are going to be involved in transportation advocacy. So that would be a good place to start for a lot of people. To kind of piggyback off of that question, in Metro Detroit, for example, just as an example, in Southeast Michigan, a little more broadly, that there's been a lot of effort to try and get better regional transportation, but not a lot of success. And one of the issues that we run into a lot is that people who are trying to work, they work in one community and live in a different community, and that there's not necessarily a direct route between those two areas if it's 20-30 minutes away by car. What are some possible solutions to that kind of lack of integrated or unified regional transportation?
Sarah, do you want to try to answer that really difficult question?
It's politicized as well. If these townships don't believe that they'll ever have a need for transit, and that's just not the case. As you know, as we're all aging, as the baby boomers are aging, there is a need for transit at some point in your life. If not you for your family member, it's political. And first mile, last mile has got some things. If we can get you to the end of the route, then could you get a circulator to pick you up? We're looking at all these options, but.
And I included a little bit about microtransit. I didn't speak to it, but that is being used a little bit privately, but also with public transit as a complementer, where they're able to sort of test out these first mile, last mile solutions. But, to me, it comes down to, again, are we going to put the money where we need to or not? And are they going to be sustainable solutions? Or are we going to keep testing pilots that spend a lot of money, but again, who is designing these solutions? And are they people on dedicated teams, or are you asking coalitions to be built from all these different people that have, 10 or so already initiatives on their plate? And so it just, to me, it comes down to prioritizing. But one thing that they are starting to do is the payment system for the different fragmented pieces of the transportation bubble that we have here. The payment system is what they've been able to start by doing. So, you can buy a pass. When you buy a DDOT pass, it's, $2 and it's for 4 hours. And I believe now with that pass, you can use Smart, or you buy a particular pass where you can use you can use Smart and DDOT. So payment is one thing that they've been able to work as a first step to getting over some of those fragmented barriers.
And one thing that when you make an app, not everybody has a smartphone,
right?
And
yeah.
Not everybody has a bank, and under federal guidelines, because we receive federal and state dollars, we have to abide by federal rules, and we have to make things accessible language-wise. We have to make things accessible for people who don't have a bank. These are important things in social justice and things that we have to keep in mind. You might have the coolest autonomous vehicle, and not everyone's going to be able to afford to have one in their driveway.
And there are pilots that there's a federal, I think there's 7 or so cities that were picked, and I'm not as sure how public this information is, but there are starting to be pilots that focus on, disabled seniors and autonomous vehicles. But even when you're trying to find these solutions, we're trying to run before we've walked. And so how can we talk about autonomous vehicles for disabled seniors in poor communities before we talk about how we're going to sustainably pay and cover autonomous vehicle costs? So autonomous vehicles, in order for them to break even, they have to be out being utilized for 90% of the day, meaning that they have to fill so many different use cases for so many people just to break even. So how do we negotiate and navigate these access issues with even the sustainability of this equipment?
Right.
I don't know, but
Another
trying to be there.
question. Yes, difficult, all challenging. Do we have any idea when autonomous vehicles might be available? I mean, there are obviously some levels of autonomous vehicles currently, but my son bikes to work and therefore can work, but still can't drive since he still periodically has seizures. He isn't in the city, so he can't use the rapid busing, and there were no other options that he qualified for other than Uber, which was too expensive to be sustainable for employment. It would be nice to be able to get a ride somehow when not living in the city, or something that can drive him. This is kind of just a very common situation, and any thoughts on, at least on the first part of that question, when there'll be more autonomous vehicles available in a wider area?
So the reality is that we, both in Southeast Michigan and Southwest Michigan and Michigan as a state, are going to be experiencing autonomous vehicles before a lot of other places. Because we have, the most engineers in any state. We have all these public-private partnerships and these car companies. So our ecosystem is developed in a way where we're going to get access to them quicker than other states. Our policies encourage it. I think for private consumption, I'm assuming 8 to 10 years. I haven't been in as many of the up-to-date spaces as I was a couple of years ago, especially with COVID. The project I was on is on pause, so I'm not as up-to-date, but I think between 8 and 10 years, although, as Sarah mentioned, May Mobility has been operating not fully autonomous, but I think they're between a level 3 and a 4. I think the way we're going to have access to them is with through public partnerships or through ride-hailing apps. So Uber, for instance, will have, that's the operating model that a lot of private companies are going towards, is working with a service provider while they're the ones sort of operating and maintaining the vehicle. I don't know if that really answers the question, but that's where my mind's at. I think 8 to 10 years, but we'll get them before other people will, fortunately.
Yeah, another quick question. Do we think that there will be the pairing of autonomous vehicles with some sort of seizure detection or technology? Is that something that is realistically possible within the next 5 to 10 years?
I think if they have included people with disabilities anywhere, it is with health concerns, because that technology already exists. It's just a matter of putting it in the vehicle and navigating privacy and health concerns in terms of how your data is being shared. So I think, yes, that's an easy thing that people, who have no experience with disability can learn quickly versus some of the other aspects of disability that are a bit more complicated.
Okay, and one more quick answer or question, and we'll have to wrap it up. If you have epilepsy and live in a rural area, are there any free options for transportation or doctor's visits or pharmacy runs, etc.? Just, I think, even more broadly speaking, rural areas can be a particular challenge, especially if you're not working or operating exclusively in your own small community. Any thoughts on
Short answer, no, not unless the community is willing to pay for it, because transportation is very expensive. And one thing I don't think people actually realize is that Uber and Lyft aren't doing well.
Mm-hmm.
They're not doing well at all. They're in serious financial trouble.
Because the hardest part of operating a mobility service, whether you're a public bus company or, like I said, wheelchair transportation, or just Uber and Lyft, is maintaining and operating the vehicle, the logistics. So if you're waiting for a Lyft and it comes in 2 minutes, that's because that driver is sitting there without a ride. But Lyft and Uber aren't losing that money, that person is. So I think, I don't know if it's still this case, but a couple years ago, the statistic I knew was that 80% of transportation network company drivers, Lyft and Uber drivers, quit within the first year. So even sustainability of that is bad. And I think it works for people that, you know, they're not using their car too much and they're doing this as a second or third job just to get a little bit of money to pay for some of the extra expenses. You know, maybe their kids are going to college, insurance. So it's, yeah, I'll stop there. But it's expensive. Yeah.
Okay, well, we are out of time, so I want to thank all three of you for such an excellent discussion. We covered a lot of ground and looked at transportation from several different angles. So again, really want to thank you for your time, and I want to thank everyone for participating in this Epilepsy Innovation Week.